Hello everyone, welcome to Dr. Ekram Explains. Today I will discuss approach to osteoporosis. This is part B that will cover osteoporosis in older men. In part A, I talked about postmenopausal osteoporosis. If you have not seen it, you will find the link in the description of this video. Alright, let's start by looking at how osteoporosis affects older men. Even though we usually hear about osteoporosis in women, men aren't spared. Older men do get osteoporosis, just not as often, and because of that, it's something that's frequently overlooked. The tricky part is that it's often underdiagnosed in men, which means many cases slip by until a fracture happens. And when men do experience fractures, their outcomes tend to be worse than in women. So the key message here is, osteoporosis in men is real, it's underrecognized, and when it's missed, the consequences can be quite serious. Now, when we look at the epidemiology, osteoporosis in men becomes more common as they age. What's striking is that about a third of all hip fractures occur in men, and their mortality after these fractures is higher than in women. Treatment rates, however, remain surprisingly low. So overall, this slide reminds us that osteoporosis in men is both more serious and less treated than many people realize. Now let's talk about why men are affected by osteoporosis. One big reason is that men are screened far less often, so problems aren't picked up early. Secondary causes, like medical conditions or medications, are also more common in men. Their bone loss tends to be gradual, which means it can go unnoticed for years. And because fractures usually occur later in life, the impact can be more serious when they finally happen. Let's take a quick look at how bone physiology differs in men. Men generally start off with a higher peak bone mass, and their bones tend to be larger, which offers some natural protection. They also lose bone more slowly as they age. But interestingly, estrogen still plays an important role in maintaining bone health, even in men. So, while men have some structural advantages, hormonal changes can still significantly impact their bone strength. Now, when we think about the clinical implications for men, the big issue is that their fracture risk is often underestimated. In practice, this means osteoporosis isn't top of mind for many clinicians when assessing older men. Because of that, the diagnosis is frequently delayed, and we miss the window to intervene early. On top of this, secondary causes are common, which complicates things further. And once a man has had a fracture, his future fracture risk becomes significantly higher, so early recognition really matters. Now let's take a quick look at the overall causes of osteoporosis in men. One of the most important points here is that secondary osteoporosis is very common in men. Things like medications or chronic illnesses often play a big role. Primary osteoporosis does occur, but aging itself contributes significantly to bone loss. And in many cases, the causes are multifactorial, meaning several factors are acting together to weaken bone. Now let's talk about hypogonadism, which is a really important secondary cause of osteoporosis in men. When testosterone levels are low, it has a direct impact on bone health. But it's not just testosterone. Estrogen deficiency also matters, because men rely on estrogen too for maintaining bone strength. With both hormones reduced, bone resorption increases, meaning bones break down faster. And as a result, fracture risk goes up significantly. So, identifying and managing hypogonadism is a key part of evaluating osteoporosis in men. Next, let's look at some medication-related causes of osteoporosis in men. One of the most common contributors is glucocorticoid use. These steroids can significantly weaken bones over time. Androgen deprivation therapy, often used in prostate cancer, is another major factor. We also see anticonvulsants increasing risk in long-term users. The key message here is that many commonly used medications can quietly harm bone health, especially when taken for long periods. Now let's look at some of the chronic diseases that increase osteoporosis risk in men. Chronic kidney disease is a major one because it disrupts calcium and vitamin D balance. Chronic liver disease also affects nutrient metabolism, which weakens bone over time. Then we have malabsorption syndromes, where the body simply isn't absorbing the nutrients needed for bone health. And finally, inflammatory disorders can accelerate bone loss as part of the disease process. Now let's look at some lifestyle factors that increase osteoporosis risk in men. Smoking is a big one. It accelerates bone loss. Excess alcohol is also common and can really weaken bones over time. Low physical activity means the bones aren't getting the stimulus they need to stay strong. And finally, poor nutrition, especially not getting enough calcium or vitamin D, can contribute significantly to bone loss. These are all modifiable, so addressing them makes a real difference. So let's talk about how osteoporosis actually shows up in men. In the early stages, it's often completely asymptomatic, so most men don't realize anything is wrong. For many, the first real sign is a fracture, which is why early screening is so important. After a fracture, men typically experience significant pain, and this can lead to a decline in mobility and overall function. So, even though the disease is silent at first, the consequences can be quite serious. Now let's talk about fragility fractures. These are fractures that occur with minimal trauma, often from something as simple as a fall from standing height. And when a fracture happens this way, it's essentially diagnostic of osteoporosis. What's important to remember is that a fragility fracture doesn't just tell us about the current bone health, it also predicts future fractures, which means these patients need prompt evaluation and treatment. Let's take a look at the common fracture sites in men with osteoporosis. Hip fractures are very common, and they're often the most serious. Vertebral fractures are also frequent, though many of them can be silent at first. Wrist fractures are less common in men compared to women, but they still occur. And we shouldn't forget pelvic fractures, which can also result from low-impact injuries. Altogether, these sites highlight how widespread and serious fragility fractures can be. Now let's talk about silent vertebral fractures. These fractures are often completely asymptomatic, so men may not even realize one has occurred. Many of these fractures are found incidentally on imaging, done for other reasons. A loss of height can be an important clue that a vertebral fracture has happened. And even though they're silent, these fractures significantly increase the risk of future fractures, so identifying them is really important. Now let's talk about the mortality impact of osteoporosis in men. Unfortunately, men have a higher mortality rate after fractures compared to women. Hip fractures carry the greatest risk, often leading to serious complications. Comorbidities, like chronic illnesses, also contribute to poorer outcomes in men. And this is why early identification and prevention are so important. The earlier we act, the better we can reduce these serious risks. Now, when we think about evaluating osteoporosis in older men, there are 4 key goals to keep in mind. First, we want to confirm the diagnosis of osteoporosis. This means looking at bone mineral density, clinical history, and any evidence of fragility fractures to make sure we're identifying the condition accurately. Second, it's essential to identify any secondary causes. In men, secondary osteoporosis is common, so evaluating hormonal status, medications, and chronic conditions is a critical part of the assessment. Third, we aim to assess the patient's overall fracture risk. This involves more than just bone density. Age, fall risk, comorbidities, and lifestyle factors all play a significant role. And finally, once the risk is clear, the goal is to guide appropriate treatment decisions. This ensures that therapy is tailored to the patient's risk profile, helping prevent future fractures and improving long-term outcomes. So, overall, the evaluation process helps us diagnose accurately, uncover contributing factors, estimate risk, and choose the right management approach for each individual. Now, when we assess fracture risk in older men, it's important to remember that the risk is multifactorial. Bone density certainly plays a role, but it's only one part of the picture. As men get older, their absolute fracture risk increases, even if their bone density doesn't look severely low. That's because aging itself contributes to bone fragility and increases the likelihood of falls. And speaking of falls, falls contribute significantly to fracture risk. In fact, many fractures in older men occur not because the bones are extremely weak, but because a fall happens in the first place. So, when we evaluate fracture risk, we look beyond the DXA scan and consider age, comorbidities, medications, balance issues, and overall fall risk. In short, fracture risk assessment is a holistic process, combining bone density with all the other factors that influence whether a fracture is likely to occur. The FRAX tool helps estimate a man's 10-year fracture risk by combining clinical risk factors with or without bone density results. It's especially useful because many older men have significant fracture risk even when their BMD isn't severely low. FRAX integrates age, prior fractures, smoking, alcohol use, steroid exposure, and other factors to provide a clearer overall risk profile. This makes it an important guide for deciding when to start treatment and how intensive therapy should be. Risk stratification helps categorize men into low, moderate, or high fracture risk groups. This classification is essential because it directly guides the intensity of treatment and follow-up needed. Low-risk patients may only need lifestyle measures, while moderate-risk individuals often require medication. High-risk men need more aggressive therapy to prevent fractures. Importantly, risk stratification is a dynamic process. Patients should be reassessed regularly, as their fracture risk can change over time. When evaluating osteoporosis in older men, we begin with a set of baseline laboratory tests. These help identify secondary causes and guide further management. We check serum calcium and albumin to assess corrected calcium levels. Renal and liver function tests are important because organ dysfunction can affect bone metabolism. A vitamin D level is essential, as deficiency is very common. And finally, a full blood count may reveal underlying conditions that contribute to bone loss. DXA scanning is the standard diagnostic tool for assessing osteoporosis in men. It measures bone mineral density at the hip and spine, which are the most clinically relevant sites. We use the lowest T-score from these areas to make diagnostic decisions. However, in older men, degenerative changes in the spine, like osteoarthritis, can falsely elevate spinal BMD. That's why hip measurements are often more reliable and play a key role in accurately assessing fracture risk. When interpreting T-scores in men, it's important to remember that the female reference database is used for diagnosis. A T-score of -2.5 or lower remains the diagnostic threshold for osteoporosis. This criterion applies to men aged 50 and above, ensuring consistency across populations. Studies show that men and women with the same T-score have a similar fracture risk, so using the female reference range provides an accurate and reliable way to identify osteoporosis in older men. When interpreting bone density in men, the Z-score provides an age-match comparison, showing how a patient's bone density compares with others of the same age group. A low Z-score is concerning because it suggests that bone loss is greater than expected for age. This often points to secondary causes of osteoporosis, such as endocrine disorders, chronic disease, or medication effects. A low Z-score should therefore trigger further evaluation to identify and address any underlying conditions. A diagnosis of osteoporosis can be made even without a DXA scan when a fragility fracture is present. In these cases, treatment should not be delayed, as the fracture itself is already diagnostic. A DXA scan is still useful later to provide a baseline for monitoring and long-term management. The priority here is secondary prevention, ensuring that men who experience a fragility fracture receive prompt evaluation and treatment to reduce the risk of future fractures. Hormonal evaluation is an essential part of assessing osteoporosis in older men. Serum testosterone should be measured because low levels are a common and important contributor to bone loss. A morning sample is preferred, as testosterone levels peak earlier in the day and provide the most accurate assessment. Identifying low testosterone helps uncover secondary causes of osteoporosis and guides appropriate management, since hormonal deficiency directly contributes to reduced bone strength and increased fracture risk. Additional testing is guided by any abnormalities found on initial evaluation. When results suggest endocrine issues, these should be carefully evaluated, as hormonal disorders are a common secondary cause of osteoporosis. Malabsorption should also be considered, especially when nutritional deficiencies or gastrointestinal symptoms are present. Finally, it's important to exclude malignancy, since cancers, particularly those affecting bone or bone marrow, can contribute to significant bone loss and increased fracture risk. So, diagnosis of osteoporosis in older men is often delayed, largely because the condition is under-recognized and secondary causes are common. A fragility fracture is sufficient to define the disease and should immediately prompt treatment, even before a DXA scan is performed. DXA remains valuable to support the diagnosis and provide a baseline for monitoring. Ultimately, evaluation should follow a risk-based approach, ensuring management aligns with each patient's fracture risk profile. Treatment is recommended for all older men with a fragility fracture, regardless of bone density. Men with a T-score of -2.5 or lower also require pharmacologic therapy. In men with osteopenia, treatment decisions are guided by overall fracture risk, often using FRAX thresholds. Importantly, secondary causes of osteoporosis should be identified and managed alongside pharmacologic treatment. This integrated approach ensures that therapy targets both the underlying cause and the resulting fracture risk. The main goals of treating osteoporosis in older men are clear and clinically important. First, we aim to prevent fragility fractures, which are often the earliest and most serious complications. Treatment also focuses on maintaining bone strength over time to reduce future fracture risk. By doing so, we help preserve mobility and independence, which are critical for healthy aging. Ultimately, effective management helps reduce morbidity and mortality associated with osteoporotic fractures. Lifestyle measures form an essential foundation of osteoporosis management in older men. Weight-bearing exercise is strongly encouraged, as it helps maintain bone strength and overall physical function. Smoking cessation is critical because smoking accelerates bone loss. Men should also limit alcohol intake, since excess alcohol weakens bone over time. Finally, implementing falls prevention strategies, such as balance training and home safety measures, helps significantly reduce fracture risk. Adequate calcium and vitamin D intake is essential for managing osteoporosis in older men. Calcium provides the building blocks for bone, while vitamin D ensures proper absorption and supports bone metabolism. Vitamin D deficiency must be corrected, as it is common and contributes to bone loss. When dietary intake is insufficient, supplements are recommended to maintain appropriate levels. These nutrients should be optimized before starting drug therapy, as they are necessary for treatment effectiveness. Bisphosphonates are the first-line therapy for treating osteoporosis in older men. They have proven fracture reduction benefits, making them a reliable and widely used option. These medications are available in both oral and intravenous forms, allowing treatment to be tailored to patient preference, tolerance, and comorbidities. Overall, bisphosphonates are suitable for most men with osteoporosis and form the foundation of pharmacologic management aimed at improving bone strength and preventing future fractures. For men who cannot take bisphosphonates or who remain at high fracture risk, we consider alternative therapies. Denosumab is an effective option and is often used when bisphosphonates are unsuitable. In men with severe osteoporosis or multiple fractures, anabolic agents may be indicated, as they help build new bone rather than just prevent bone breakdown. After using an anabolic therapy, sequential treatment with an anti-resorptive medication is important to maintain the gains in bone density and reduce future fracture risk. Monitoring treatment in older men with osteoporosis is essential to ensure therapy is effective and well tolerated. We begin by checking for any new fractures, as these indicate inadequate response or worsening risk. Repeat DXA scans are performed periodically to assess changes in bone density. It's also important to evaluate adherence and tolerance to medication, since poor compliance reduces treatment benefit. Based on these findings, therapy can be adjusted accordingly to maintain optimal fracture prevention. The duration of osteoporosis treatment in older men is generally long-term because fracture risk persists over many years. How long therapy continues depends on the individual's ongoing fracture risk, response to treatment, and overall health status. It's important to reassess regularly, using clinical review and bone density measurements to determine whether the current approach remains appropriate. Ultimately, decisions about continuing, modifying, or pausing therapy should be individualized, ensuring each patient receives the most effective and safe long-term management. Drug holidays may be considered for men who have been on bisphosphonates for several years, but only if they are at low fracture risk. These breaks help reduce the small long-term risks associated with continued therapy. During a drug holiday, it's essential to monitor bone density and fracture risk closely to ensure stability. If bone loss progresses or fracture risk increases, treatment should be restarted promptly. Overall, drug holidays must be individualized and carefully supervised. Osteoporosis in older men carries significant long-term consequences. Fractures increase mortality, particularly in men, who often experience worse outcomes than women. Hip fractures are the most serious, frequently leading to complications, hospitalization, and loss of independence. Many men face persistent disability after a major fracture, affecting mobility and overall quality of life. Importantly, fracture risk persists lifelong, meaning ongoing prevention, monitoring, and treatment are essential to reduce future fractures and improve long-term prognosis. To wrap up, there are 4 key messages to remember about osteoporosis in older men. First, osteoporosis is common yet underdiagnosed, often because it's still viewed as a women's disease. Second, secondary causes are frequent, making thorough evaluation essential. Third, a fragility fracture is diagnostic, meaning treatment should start immediately without waiting for a DXA scan. And finally, early treatment saves lives, helping prevent future fractures, reduce disability, and improve long-term outcomes for older men with osteoporosis. This slide provides a selection of further reading resources for those who want to explore osteoporosis in older men in more depth. Thank you for joining me for this session on osteoporosis in older men. If you found this helpful, feel free to comment, like, share, and subscribe this channel. Thanks again for watching, and I look forward to seeing you in the next session.